This week on the Frontiers of Medicine. They say medicine is as much an art as a science. In a special episode of Frontiers of Medicine, we'll show you an inside look at the miracle and beauty of the human body.
So here's your ventricular system in the cyan, and you see your blood vessels, and there's your tumor.
It is a terrifying diagnosis. The patient, we'll call her Stephanie, is just 29 years old and has a tumor growing deep inside her brain.
I first noticed it about 5 months ago. I had a spell where I would lose some of my language capabilities, my words. I would look at a door and not know what it was called. If you said it, I would know that you were correct. That's what I was talking about, but I couldn't tell you the word for it. And I would lose vision in my left eye.
Good.
As Stephanie undergoes surgery at the Mayo Clinic in Rochester, Minnesota, a local anesthetic keeps her awake, so surgeons can monitor effects on her brain's language center that is adjacent to the mass.
Great. Now you're going to hear either Dr. Meyer or me say, go, and that's when I'm going to show you the picture, okay? And as soon as you see it, you just tell me what it is. Good.
It is an astonishing procedure made possible by new, advanced three-dimensional imaging. While conventional magnetic resonance and CAT scan technology creates a sense of depth, the new imaging shows the patient's brain as a volume seen from any direction in real time.
Overall, I was quite happy with this patient's operation. She had a benign tumor which was adjacent to eloquent language cortex. My estimation, based on our intraoperative stereotaxis, is that we obtained a gross removal of the tumor.
To show volume, algorithms must be written that extrapolate all of the visual detail one layer to the next. The graphic images of the brain and other organs are made up of pixels. Once the boundaries of an anatomic structure are determined, the pixels within it are systematically segmented and classified, each layer, each anatomic structure. To convert flat, two-dimensional axial photographs into 3D models, many computer imaging scientists use what is called a voxel. A voxel is a pixel in 3D. All of this stems from a little-known U.S. government initiative which promises revolutionary new medical breakthroughs as dawn breaks on a new millennium.
Funding for this program is provided by the Medtronic Foundation, celebrating Medtronic's 50 years of pioneering therapies that restore health, extend life, and alleviate pain. Medtronic, when life depends on medical technology.
Welcome to Frontiers of Medicine. For centuries, the mysteries of the human body have remained largely hidden from doctors and researchers. But now, that's all changing, thanks to the Visible Human Project.
The Visible Human Project, 3D visualization. Today's new doorway to the soul of medical understanding dates its origins to 2nd century Greece, when the physician Galen created woodcuts based on human anatomy. Yet the science of anatomical illustration took a back seat to superstition, and for more than 1,000 years there was little advancement in the art of Western healing. Until the late Middle Ages, when Renaissance physicians systematically began to probe and diagram the skeletal and organ systems in a search for factual understanding. But only in the 20th century did anatomical study become truly objective, with microscopes, X-rays, and later magnetic resonance. Even then, imaging was two-dimensional at best. Most illustrations still were derived from photographs. Doctors still were left trying to see what was inside the human body from outside the human body. This is why the visible human technology that helped save Stephanie's life is being called as revolutionary to medical understanding as Gutenberg's printing press was to world literacy 500 years ago.
For example, in this patient, we were able to look at her tumor beforehand, understand its relationship to her brain, and plan the operative approach.
When the Mayo Clinic surgeons performed the surgery on their young patient, any sense of déjà vu was real. They had been there before, in Stephanie's brain, in virtual reality.
One of the greatest advances in neurosurgery has been the advent of very sophisticated imaging to look at patients, and also the reformatting of images. The ability to take an MRI scan and reconstruct it so you get a three-dimensional display is very advantageous.
And the Mayo Clinic also is developing 3D diagnostics for the prostate and other organs.
Every patient's anatomy is a little bit different. None of us are average. So the prostate gland, of course, is a little smaller or larger. The bladder's in a little different position. Where the urinary sphincter is a little different. Obviously, where the cancer, the pathology is relative to all these sensitive structures is different. Knowing these ahead of time preoperatively, as precisely as possible, gives the surgeon these critical margins, these important information about the margins. Where should I operate? Where should I stay away from to try to avoid complications?
On what is this extraordinary new technology based? The answer can be traced to the National Library of Medicine in Bethesda, Maryland, where the Visible Human Project was born in 1986. At that time, no human digital data sets existed. But library officials foresaw a coming era when the bibliographic and factual database services of the National Library would be complemented by libraries of digital images. An increasing role was envisioned for electronically represented images in biomedical research and clinical medicine. And the library, part of the National Institutes of Health, set about to compile the human data sets from actual cadavers. A national search was undertaken to find suitable donors. In 1988, a federal award was made to a research consortium headed by the University of Colorado School of Health Sciences, and it set the criteria for selecting the visible man and the visible woman. In 1995, the female, a state of Maryland resident, was chosen.
She was a housewife who, the story goes, was never sick in a day in her life, and woke up one morning and was dead. And the transplant team visited the husband, we're told, and suggested that since his wife had always been so healthy, that she would be perfect for a transplant.
The visible woman's counterpart came from a Texas prison, an inmate who, while awaiting execution, chose to make a contribution to mankind.
He was under sentence of death and had committed a double murder. But he took it upon himself to donate his body, and I say we have to be grateful to him as well.
Many others had willed their bodies for scientific research. The Texas inmate and the Maryland housewife were selected because they were considered normal references. They were not too young or too old, did not have medical histories of infectious disease, metastatic cancers, major surgeries, implants, or prostheses. The Adam and Eve database had to be based on individuals who had been in good health until the very moment they died.
In the case of the female, this was a lady who actually is perhaps the most fully informed consent I've ever heard of, because she and her husband actually read an article, I think in the Atlantic Monthly, describing the visible male. Within 30 days, totally unsuspected, the lady developed an illness, I think a myocardial infarction, and became deceased, and her husband carried out her wishes.
To create digital photographic data, the cadavers underwent magnetic resonance imaging and CAT scans, were frozen to 90 degrees below zero, and cryosectioned. The Texas prisoner in 1 millimeter cross sections, the Maryland housewife into 1/3 millimeter increments. 3 different cameras photographed each section, in a process repeated some 2,000 times for the visible male and more than 5,000 times for the visible female. These images are the raw data that were cropped, aligned, and converted into the visible human data sets, encased in one computer at the National Library, home to today's 55-gigabyte cybercouple, a virtual reality Adam and Eve.
The only ethical consideration in it, as it turned out, if you have somebody who is all but normal, other than they're dead, so they're all but normal, what about the ethical consideration of denying organ transplant because they might become the visible man or the visible woman? As it turned out, there were donations to the project, or donations, if you will, to science as opposed to transplant, and so those ethical problems were actually made by the family or by the now deceased.
Universities and medical technology companies are taking the visual human data and reaching new frontiers of medicine. Their innovations allow surgeons hundreds of miles apart to consult on an operation. Medical students can take a virtual tour of the inner ear, and that's just the beginning.
The national grid, which is going to be a high-speed network linking supercomputers together, will enable us to extract data, compute the data, and visualize the data.
Okay, thanks very much.
This is not your ordinary teleconference.
As we view this model in 3 dimensions, we can make a little trip down the ear canal to see what's down at the end of the ear canal.
From a Chicago hospital, this doctor transmits visible human data live and with the help of special goggles in 3D. A medical team in San Jose, California can consult with a specialist from half a continent away.
And as you can see here, here is the eardrum, and it's vibrating to the sound of my voice.
I think people understand it without seeing it best if you say it's like the Star Trek holodeck. It's not quite that sophisticated, but it's almost. In the cave technology, you can actually walk into the visualization of your data. The visualization of data is absolutely revolutionizing the way we think and work.
The Visible Human Project has taken anatomy from the library shelf to the hands of physicians and researchers the world over, who can get inside their patient's skin before ever making an actual incision. Doctors can move freely, traveling the inner landscape of the body. The computer can remove skin, muscle layers, and take the image right down to the bone.
And what we've done with this CT data is just segmented the data based upon different densities. Now what we want to do is select a threshold that will represent the skin, the muscle, and also the bone.
The virtual bronchoscopy is another example of cutting-edge medicine, enabling physicians to help patients without making a cut or even bruising a patient's delicate tissues and organs.
With our bronchoscopy system, we've collaborated with Penn State's Hershey Medical Center. Using the visible human data, we've actually reconstructed the bronchial tree and a lung model so that now a physician can go in with a virtual bronchioscope and they can explore and learn how to navigate that scope prior to patient contact.
It's very precise. It's very precise, and it's infinitely better from the point of view of the surgeon or the radiotherapist than any other method of planning the therapy, let's say.
Blow your breath out. Take another breath in and hold your breath.
Physicians at the Wake Forest University School of Medicine in North Carolina are developing new techniques for the early diagnosis of colorectal cancer, the second leading cause of cancer deaths in the United States today.
We've developed central path algorithms that will take us into the center of the bowel, and we can automate our 3D camera along that pathway.
Each procedure is based on extrapolating the Visible Human Project's Adam and Eve to the unique data set of the individual patient.
As a radiologist and clinician, I see this as a way of screening the mass population down the line.
Here's a lesion where we now see a pseudo-coloring of that polyp, which the computer has done on its own. The computer has actually gone through, searched the bowel for potential abnormalities, and provided us with a list of lesions that it has found.
Once the technology is worked out on how to do those simulations, then the patient presents with their CAT scans and their MRIs. And the visible human data is morphed. That is, it's changed by the computer into the shape and into the form of the CAT scans which are presented by the patient.
Faster computer technologies and transmission bandwidths must be developed before patients at most local hospitals can benefit from 3D diagnosis. Depending on the medical center, the data extrapolation rates can vary from a few minutes on some supercomputers to a few weeks.
If we can reduce the incidence of colorectal cancer in this country, there will be tremendous cost savings. The potential cost savings that virtual colonoscopy affords the U.S. is over $1 billion a year.
Once we were only able to theorize about the inner workings of the human body. Now, thanks to the Visible Human Project, we can take a virtual 3D tour. But if its creators saw great potential back in 1986, what do they see for the next 15 years? Here's a look.
There are certain important things to consider before beginning IV therapy.
For certain procedures, the future is here and now. Surgeons today can plan new complex procedures. Specialists can devise better diagnostics. Doctors and medical students can strip away layers, see behind organs, and enter structures just as they would with a lab cadaver. But unlike a cadaver, the virtual human can be dissected again and again.
I hate to use the word revolutionize medical training. I think it will. It's a standard cadaver that everyone can interact with, both yourself and the next generation. You can both work on this same cadaver or derivatives of it. I think that's going to change a lot the way we teach.
Basic anatomy now can be taught with new technique, and the information can be transmitted from supercomputers to medical supermodels.
We are one of the end producers of some things of that data, where we're making the models themselves. We've made a plastic back that you can now do a needle insertion simulation on to do a celiac plexus block.
When a doctor practices a procedure, the models filled with data seem to come to life. The latest software programs simulate the behavior as well as the look of internal organs and tissues.
Because on the other side of that plastic model, we have motors that hold on to the other end of the needle that you think is going into his back. It's really going into his data. And those motors are giving you forces that are representative of his muscles, his bones, his tissue, his aorta in his back. And in fact, we could generalize that to stick a needle anywhere in his body.
Remarkably, the models seem to feel.
This is something that's never been able to happen before. The trainee can learn from many different complications, and many trainees can learn from the same complication.
The software takes into account the different textures and flexibilities of muscles and organs.
This is so real, it's frightening. The effect we were looking for when we started was to make people forget that this is a virtual patient, that what they're working with is a computer, and make them think that what you're looking at is a real patient. And that's how it looks and that's how it feels. The input devices are actual devices that I use every day.
Physicians sometimes can't tell the difference between these simulated images and real life patients. And that's our goal, is to make that scene look so realistic that the physician doesn't know if they're working on a computer or are they working on a patient.
In much the same way that high-tech flight simulators put airline pilots in the captain's seat to practice for unforeseen or sudden hazards, the visible human data puts visual data at the surgeon's fingertips. Medical schools hail the simulators as an important breakthrough, preparing both experienced surgeons and untested young doctors to simulate the surgical experience.
This is a remarkable step forward. Really what we should be doing with this information technology. We should be learning on machines, not on patients.
Data is beginning to be utilized not only to validate structures that we are finding, but helping in the identification of structures never described in the literature before.
in an era in which it often seems there is nothing new under the sun, the new three-dimensional imaging also has led to new anatomical discoveries.
One is a previously undescribed muscle that runs from behind the eye socket to the mandible, which is the lower jaw. The other discovery is a muscle-dural connection. This is a connection in the back of the neck between deep neck musculature and the spinal dura. We hope to develop biomechanical models using the visible human data set to show what happens to that tissue when the head and neck are moved in various positions. And this may help us solve the puzzle, at least in part, in terms of head and neck pain.
It is another highly significant development based on the National Library of Medicine's Visible Human project. Available now on CD-ROM and on the internet, the visual information is being applied to other areas of life not envisioned when the concept first sprang into being at NLM. For example, the visible humans also may be saving lives in other ways. The data sets are being used to help design cars that are more accident survivable. In short, creating virtual crash dummies in cyberspace.
There are people that are using visible human to produce virtual crash dummies to put in the virtual cars. So that not only can you see the effect on the steel, but the more important, you don't want a situation where the steel survives but not the driver. More important, the driver survive and the steel take the beating if that's the way it has to be.
Visible human data sets also are becoming another evidentiary tool in state and federal courtrooms alongside fingerprints and DNA data. A post-World War II science fiction movie, Fantastic Voyage, foretold the inner space exploration of the human body. Today it is science, not science fiction. Since 1986, medical illustration has become much more than a book on a shelf. With photographic realism, we can now enter virtual space and explore human anatomy without intrusion. And more applications are being developed on an almost daily basis. The National Library of Medicine has issued more than 1,100 licenses in more than 30 countries.
One of the big challenges when we first started working in this area is we were working with the world's most powerful graphic supercomputers to develop this technology. And we'd set these things up and physicians would say, this is incredible. This is what we need to enhance education. But what's that refrigerator over there? And I'd say, that's not a refrigerator. That's the computer that we need to use to build simulators. Well, really the revolution that's happened in information technology has brought that refrigerator to the desktop. The next step for this technology will really be to take patient-specific data, put it into the simulators, and allow for patient-specific preoperative rehearsal.
We're entering the new millennium, let's say 2010. It should be at your favorite hospital.
The data sets even are showing up in the world of art. Like the revolution in knowledge brought about by Gutenberg's invention of the printing press, the visible human technology is leading to advances in every aspect of science and in fundamental aspects of daily human existence. Learning is becoming more and more visual and virtual.
There's no doubt that this will become as second nature to the learning process currently as looking at books are, reading books are now.
My feeling is that we're going through a very important segment of our history that is allowing people to be visually literate. Whether it's medicine, history, architecture, they can make better judgments. They can look at information in a whole different way and very quickly make more appropriate judgments.
And the most important visual step forward is in public health. The visible humans have become surrogates for each of us. They feel no pain, no anxiety. It started out with the creation of Adam and Eve in virtual reality, cadavers in cyberspace. Now, the visible humans are touching people around the world with a world of possibility.
Remember, the more information you have, the better healthcare consumer you'll be. A good place to start is our website, which has information about the stories covered by Frontiers of Medicine, plus links to other health information.
In a segment about the common cold in show number 207, a quote by Dr. Paul Serbaugh was mistakenly included in this story and referenced RSV, the respiratory syncytial virus. RSV is a virus that causes serious lower respiratory tract infections in infants and children younger than 4 years of age. Although RSV causes cold-like symptoms and is quite prevalent, it is not the common cold, and neither is it believed to cause the common cold.
Thanks for watching. I'll see you next time on The Frontiers of Medicine.
Funding for this program is provided by the Medtronic Foundation, celebrating Medtronic's 50 years of pioneering therapies that restore health, extend life, and alleviate pain. Medtronic, when life depends on medical technology.